Metabolic bone disorder. Osteoporosis. Simplified notes. Definition. Osteoporosis is a condition where bones become weak, brittle, and are more likely to fracture. It is the most common bone disease globally. Over 1.5 million fractures happen every year due to osteoporosis. Causes. 1. Primary osteoporosis. Occurs naturally with aging, common in postmenopausal women and older men. 2. Secondary osteoporosis. Caused by medications or diseases affecting bone health, e.g., steroids, celiac disease, alcohol abuse, seizure medications. Risk factors. Age, especially over 50. Female gender, especially postmenopausal women. Small body frame. Family history. Low calcium, vitamin D intake. Sedentary lifestyle. Smoking and alcohol. Long-term use of certain drugs, steroids, thyroid hormones, SSRIs, PPIs. Gastrointestinal issues, e.g., celiac disease, bariatric surgery. Immobility. Prevention. Develop strong bones by age 18 to 25. Adequate calcium 1,200 mg per day and vitamin D intake. Regular weight-bearing and resistance exercises. Avoid smoking, alcohol, caffeine, and soft drinks. Early screening for at-risk groups. Pathophysiology. Normal bone balance is lost. Osteoclasts break down bone faster than osteoblasts can build it. Results. Bones become porous, fragile, and prone to fracture. Common fractures. Spine, vertebral compression, hip, wrist Coles fracture. Signs and symptoms. Often no symptoms until a fracture occurs. Loss of height, stooped posture, kyphosis or dowager's hump. Back pain, fractures from minor falls or stress. Diagnosis. DEXA scan. Measures bone mineral density, BMD, gives a T-score. Normal. T-score greater than -1. Osteopenia. T-score between -1 and -2.5. Osteoporosis. T-score less than -2.5. Frax tool. Estimates 10-year fracture risk based on risk factors. Geriatric considerations. 50% of women greater than 80 years have osteoporosis. Hip fractures in elderly men are more dangerous. Older adults absorb less calcium and may need supplements. Routine spinal X-rays are not recommended but may detect fractures incidentally. Key points. Osteoporosis is preventable and manageable. Early detection and lifestyle changes are crucial. Men can also be affected, especially with secondary causes. Loss of estrogen in women and testosterone in men increases bone loss with age. Assessment and diagnostic findings. X-rays. Can't detect osteoporosis until 25 to 40% bone loss. DEXA scan, dual energy X-ray absorptiometry. Measures bone mineral density, BMD, at spine and hip. Results given as T-scores. Normal. T-score is greater than or equal to -1. Osteopenia. T-score between -1 and -2.5. Osteoporosis. T-score is less than or equal to -2.5. When to do DEXA. Women greater than 65 years. Postmenopausal women greater than 50 years with risk factors. Anyone with an osteoporosis-related fracture. Frax tool. Predicts 10-year fracture risk. Treat if. Hip fracture risk greater than 3%. Other major fracture risk greater than 20%. Blood tests. To rule out other diseases like cancer, osteomalacia, or hyperparathyroidism. Check calcium, phosphate, ALP, ESR, testosterone in men. Medical management. 1. Nutrition. Calcium, 1,000–1,300 mg per day. Sources. Milk, cheese, yogurt, broccoli, canned salmon with bones. Vitamin D, 800–1,000 IU per day. Needed for calcium absorption. 2. Exercise. Weight-bearing exercise, walking, jogging, dancing. Not helpful. Swimming. Improves bone strength and balance. Pharmacologic therapy. A. Calcium and vitamin D supplements. Taken with food or vitamin C drinks. Side effects. Constipation, gas. Split the dose throughout the day. B. Bisphosphonates. First-line drugs to slow bone loss. Examples. Alendronate Fosamax weekly oral. Risedronate Actonel weekly oral. Ibandronate Boniva monthly oral. Zoledronic acid reclassed yearly IV. Instructions. Take on empty stomach, in the morning, with a full glass of water. Stay upright for 30 to 60 minutes. Side effects. GI upset, ulcers, rare jaw bone damage. Avoid if recent dental work is planned. C. SERMs selective estrogen receptor modulators. Example. Raloxifene, Avista. For postmenopausal women, preserves bone density without estrogen side effects. Avoid in women with a history of blood clots PTE. D. Teriparatide Forteo, injectable PTH used daily. For high-risk patients, builds bone by stimulating osteoblasts. Not used in patients with prior radiation or bone cancer risk. E. Denosumab Prolia, monoclonal antibody injection every 6 months. Used if other drugs fail or not tolerated. Inhibits bone breakdown, reduces fractures.